Welcome to IMED Radiology's Brain in Focus webinar. My name is Kate Sliver and I'm the Sales and Marketing Manager at IMED Radiology for New South Wales, ACT and WA. Tonight's webinar will feature a highly respected neuroradiologist, Dr Lynette Masters, who will lead our session focusing on imaging pathways for investigating neurological conditions. We are also fortunate to have Dr Stephen Green as our facilitator for the evening. Dr Green is a general practitioner from Warner Vale on the Central Coast in New South Wales and has been working in general practice on the Central Coast for over 30 years. Dr Green graduated from medicine at the University of Sydney and subsequently completed his fellowship in general practice at the Royal Australian College of General Practitioners. Dr Green has a special interest in workers' compensation, including treating injured workers and managing their rehabilitation and return to work. He was a clinical lecturer for the University of Sydney at the Sydney Adventist Hospital Clinical School campus for over 5 years. He is currently involved in a research project at Monash University in the Improve trial, which involves studying the benefits of the implementation of work-related mental health guidelines in general practice. Before I hand over to Dr Green for tonight, I do have a few housekeeping items to mention. If you have any questions during the presentation, please send those through and we will endeavour to answer those as many as we can during the time frame of the webinar. At the conclusion of the webinar, please make sure to stay on to complete your evaluation form for your RACGP points. Now I will hand over to Dr Green to introduce Dr Lynette Masters.
Thank you, Kate, for your introduction. I would like to thank IMED for the opportunity to participate in tonight's webinar and indeed for conducting the webinar for the benefit of our GP attendees. Tonight's talk will focus on aspects of neuroradiology, in particular the investigations indicated for unexplained chronic headaches and for unexplained seizures. Tonight's topic is very relevant to practice. The ability to appropriately investigate chronic headaches and unexplained seizures at the initial general practice setting allows us to streamline our patients' management. This will then enable us as GPs to provide more relevant information for our neurologist or neurosurgeon at the initial practice, at their initial consultation, allowing a more timely connection for further specialist management. We're very fortunate tonight to have Dr Lynette Masters conduct tonight's presentation. Dr Masters is a neuroradiologist working at IMED Radiology in Sydney. She obtained her FRACP in neurology and followed this by undertaking radiology training. She completed a 2-year diagnostic neuroradiology fellowship at Medial Hospital Cornell Medical Centre and the Memorial Sloan Cancer Centre. She then completed a 2-year interventional neuroradiology fellowship at New York University Medical Centre. She now leads an expert imaging team that partners with the computational neuroscience team at the University of Sydney's Brain and Mind Centre. She has a special interest in spine imaging, functional MRI and research. She also has a special interest in artificial intelligence and its applications in neuroradiology. And my role for this evening's webinar will be to facilitate any questions from the audience for Dr Masters. I'll then field some questions as she proceeds, particularly if they are relevant to the slides at the time. There will also be the opportunity to address more questions at the conclusion of Dr Masters' presentation. In the event that we don't have time to address all the questions during tonight's presentation, you will receive answers to your questions post-event. During the presentation, there will also be 3 poll questions for GP attendees to answer. Your responses to these poll questions will be tallied and discussed. So now I would like to hand over to Dr Masters for her presentation. Thank you, Lynette.
Thanks very much, Stephen, and thank you very much to the college for giving me the opportunity to present this lecture. So I'm going to talk about neuroradiology and in particular imaging of the brain, but I want to also discuss more broadly the issue of MR and where it sits in the pantheon of the question of whether to use MR or CT. And so what are the strengths and the weaknesses, if you like, of the two modalities? So there is no question that MR provides superior tissue contrast and characterization, and there's no ionizing. Sorry, and there's no ionizing radiation. This is particularly important when patients are now having multiple examinations. Sorry, I'm just getting a little bit of noise in the background there. There are questions about its accessibility, which I'll come back to in a moment. And it's also important to realise that an MR is a longer study than a CT. And there are some contraindications to MR, which I'll also discuss shortly. So what are the strengths of CT? CT certainly provides superior spatial resolution, but is not as good in terms of tissue characterization. CT is generally more accessible in the community, and it's a fast study. A non-contrast CT of the brain can be but it does use ionizing radiation, which is an issue, obviously, when repeated studies are being performed. So why does MR rule? So there is no ionizing radiation. And as I said earlier, that multiplanar imaging and superior tissue contrast enable to improve lesion detection, so you can see pathology and subtle pathology that's just not possible to be seen on CT. You get a much better sense of where the pathology is anatomically, and often with MR, you can have a very good idea of what the actual pathologic process may be. So I don't want to, and I'm not going to go into the physics of MR in any detail whatsoever, but just to give you a very basic overview. So the MR scanner is basically a very strong magnetic field, and it changes the orientation of the hydrogen atoms in the body. And we're full of hydrogen atoms because they're obviously the major atom in water, and then the most plentiful atom in the body. And so the magnetic field is turned on, it changes the orientation of the hydrogen atoms, and then the field is switched off. And as these hydrogen atoms return to their steady state, they emit a small radio wave. And it's basically that forms the MR signal. The intensity of that received signal is plotted on a grayscale. And the way that these hydrogen atoms behave in different milieu, so in grey matter of the brain, the hydrogen atoms behave slightly differently to the way they behave in white matter, to the way that they behave in a brain tumour or a demyelinating lesion in multiple sclerosis. And so that enables this tissue characterization. Paul Lautber and Peter Mansfield shared the Nobel Prize in medicine in 2003 for their work in MR. So just also to mention about MR scanners. 10 years ago or 15 years ago, virtually all scanners in clinical practice were 1.5 Tesla scanners. There is an increasing move to 3T scanners in routine clinical practice. Just for your interest, there are 7T and 9.4T scanners, and there is a 10.5T scanner. And as a piece of trivia, as you can see, the 10.5T scanner in Minnesota weighs more than 3 times a Boeing 737. The clinical scanners are 1.5 or 3T, and the T refers to Tesla, which is the strength of the magnetic field. That's the abbreviation. Now, it's important to realise that the MR scanner is always on. You can't switch the MR scanner off. Or you can, but it's a very time-consuming and expensive exercise. It takes a couple of days for it to be what's called ramped down. I just show these two things because sometimes people don't understand why we're quite as anal about asking questions of patients and getting information about, you know, implants and things like that. For those of you who may have had an MR scan, you know that the radiographer will ask you to empty your pockets. And this is because once you enter the room where the MR scanner is, you're basically entering a magnetic field. And if there is anything ferromagnetic, then it can actually become a projectile and end up either within the scanner itself or attached to the scanner. And there have actually been a couple of deaths overseas where oxygen cylinders have ended up in the scanner with the patient. The scanner is always on. There are some contraindications for MRI. When I first started doing MR, there were a lot more, but we've gradually realised over the time and with testing that many things that we were concerned about in the early days do not form a contraindication. So in the early 2000s, we were concerned about prosthetic cardiac valves. And we now know that they move more in the magnetic field than in the heart than they do in the magnetic field. So some pacemakers are not MR compatible. There are some MR compatible pacemakers that are available and that are used. And I'd just like to address this very briefly. Even if a patient has an MRI compatible pacemaker, that doesn't mean that they can just hop into the scanner and have a scan. What is needed, and this is why we need information about the type of pacemaker. So when we schedule patients with MR compatible pacemakers, we have to arrange for a technician from the pacemaker company, manufacturing company, to be on site. They check the pacemaker. They then turn the pacemaker off, do an ECG on the patient. The patient then has their scan. The technician from the pacemaker company then reprograms the pacemaker and checks that the pacemaker is working. So whilst these can be done, it does require a little bit of work and pre-planning to get them done. Metallic ocular foreign bodies form a contraindication because they can potentially move within the magnetic field and cause an ocular injury. Some cochlear implants are not MR compatible, and there are some stapes implants, the older ones that were made with stainless steel as opposed to titanium, and some cerebral aneurysm clips. And again, these are very old aneurysm clips put in the 1990s, but that's why we do need information about those sorts of implants. The other thing to know is what's not contraindicated, because sometimes people have concerns about scanning patients. And joint prostheses do not form a contraindication. Similarly, metallic spinal fusion hardware doesn't. It may cause degradation of image quality if you're scanning the lumbar spine, but it does not form a contraindication. And cardiac valves and stents are safe. The other thing is it's also safe to scan a patient who is pregnant. This is scans from a patient. This patient has braces. And the reason I show that is that whilst the braces, and everyone seems to have braces these days, whilst the braces themselves do not form a contraindication to MR, they can cause moderate degradation or distortion of the image of the scan quality and may sometimes limit the information that we can obtain from the MR. So roughly, what are the indications for a brain MRI? Headache, neurologic deficit, epilepsy, stroke. These are all things that you're very familiar with and you encounter in your practice on a daily basis. What's the preparation? There is none. No fasting is required, and many MRIs do not require intravenous contrast. Some do, and I'll come back to that in a moment. Sedation is sometimes required because of claustrophobia. Now, I tend to think that it becomes a self-fulfilling prophecy, that if you tell people they may become claustrophobic, that I certainly would if I was told that I would be, there's a chance I might become claustrophobic. The chances are I would. But some people want to be forewarned. So we, in our practice, manage this patients who are claustrophobic. We ask them to come with oral sedation. We ask them to arrive at the practice a little earlier than we otherwise would, and then our staff will tell the patient when they can take their sedation to have the scan. Obviously, in those situations, we need to be sure that the patient is safe to get home, and so we usually ask that there's someone to take them home afterwards. So a routine brain MR normally takes about 20 minutes, and it depends a little bit, that varies a little bit, and it depends on what sequences are being done. And so the different sequences are done, and these provide complementary information about the anatomic location and possible etiology of any abnormality. And sometimes contrast is administered because it can provide further information if an abnormality is found. So the contrast that is used in MRI is gadolinium, which is a rare earth. And it's important to note that it does not have cross-reactivity with iodinated contrast. And so patients who have had adverse reactions to iodinated contrast can have gadolinium without sort of concerns of adverse reaction. Patients can have adverse reactions or allergic reactions ranging from mild to life-threatening with gadolinium, but the risk of a life-threatening contrast reaction with gadolinium is of the order of about 1 in a million, so it's a very safe drug. We do sometimes see mild reactions characterised by hives or some redness, which usually settles very quickly and spontaneously. As I said, it's often not needed for screening scans. It's helpful when a lesion is identified. It is usually given for skull base and orbital scans, but not for assessment of hearing loss. And it's not administered in pregnancy. And the reason that we do not give GAD to women during pregnancy is that it can cross the placenta. So that's why it's not administered. However, there is no contraindication to the administration of intravenous gadolinium if it's needed to breastfeeding women. Essentially, less than 1% of the dose of IV GAD is excreted in breast milk, and less than 1% of that 1% that is ingested by the baby is absorbed across the gut. So, the first question.
I did have a question from my participant. What sedation do you recommend if sedation is required?
Okay, so look, I would defer to my clinical colleagues very much on that one. What we generally need is usually a short-acting sedative. You know, IV midazolam was when we used to administer IV sedation, we used to give IV midazolam because it's short-acting. So often patients come with a Valium. But I think one of the reasons that it's good if the GP or the referring physician can do that is you know the patient, you know what medications they're already on, so you're the best placed person. But remembering that the study itself is only usually going to take about 20 minutes, and this is an anxiolytic dose. So we don't want the patient actually, you know, unconscious. We can monitor these patients, but it's an anxiolytic rather than a sort of very sedating dose. Most patients, if you're very positive and reassuring with them and tell them, you know, this is going to work, you'll be great with a small dose of oral sedation, do very well.
Thank you.
Okay, so the first question, which we can see there, is a fairly straightforward one, which is, sorry. Okie doke. So, which of the following may be a contraindication to MR? A cardiac stent, metallic hip replacement, lumbar fusion, or a pacemaker?
While we're waiting for that response, those responses come through, Lynette, someone just wanted to clarify the implications of dental implants in MRIs as opposed to braces.
Yeah, so again, they're not a contraindication. It's not like that great James Bond movie where Jaws ended up stuck to the magnet. So they don't form a contraindication, but they can cause some artifacts. That is more of an issue in skull base imaging, obviously, because the implants are in the same area as you're trying to interrogate. The braces can cause more significant artifacts. So then, from a routine MRI of the brain, you can still normally get a perfectly adequate diagnostic study. Skull base imaging, braces, often it's not going to fly. And if there are dental implants, unless they've got a mouth completely full of metal, we can usually get a pretty good study.
No, thank you. And one other question we have is the remote location of the hardware. How does a knee prosthesis affect spinal imaging, or conversely,
No, it doesn't, and obviously it doesn't, and that's what I'm saying. So if you've got a lumbar fusion device, if you're having a scan of the lumbar spine, then the lumbar fusion device is going to obviously cause some artifact, but the knee replacement is obviously not going to affect it. So the joint prostheses and the metallic spinal fusion does not form a contraindication to MR. If you are scanning or interrogating that specific area, it will cause artifact. Normally in spine, we can manage it. Joint prostheses, and if you're looking at that joint, so if someone's had a knee replacement and you want to do an MR of the knee, then the amount of information you're going to get is very limited, and it's probably not going to be particularly helpful.
Right. Okay. Thank you. Well, getting back to the poll now, we have 86% agree that pacemaker is a contraindication. 0.7% say spinal fusion, 8.6% say the metallic hip replacement, and 4.6% nominated cardiac stent as a contraindication.
Yeah, so as I said, of those, the only one, and hang on, I'll just go back to this. So the only one that may be a contraindication is a pacemaker. And as I said, there are now, as I said earlier, there are now some MR-compatible pacemakers, but not all of them are. And so we obviously need that information. The cardiac stents can be, patients with cardiac stents can be safely scanned, as can patients with metallic joint replacements and also metallic spinal fusion, be that lumbar or cervical. So the only thing that may form a contraindication in those is a pacemaker. So what I wanted to do was actually show you, because your patients are going to come in and they're going to bring you these scans, or you're going to look at them online and you're going to say, gee, what do you think? What are we looking at here? So what I wanted to show you was some typical images from an MR scan, and these are all axial scans, and this is what we would do as a routine, and it's 5 sequences. So on the top, going from left to right, you've got a flare sequence, and next to it you've got a T2-weighted sequence. And both of these are used for detecting pathology. And on both the flare sequence and the T2-weighted sequence, abnormalities are usually bright or white. On the bottom left is what's called a SWE, or a susceptibility-weighted sequence. It's a newer sequence which is very sensitive to the detection of blood products. So we routinely do that. In the middle down the bottom is a T1-weighted sequence, and this is used for anatomy. And you can see beautifully there cortex white matter. You can see the central grey nuclei, the caudate nuclei, and so it is used very much for anatomy. And on the bottom right is the diffusion-weighted sequence. And it was initially introduced for assessment of stroke, but it now has a much wider role. It can help, it's very sensitive with abscesses, it's very sensitive with the neurodegenerative disease called Creutzfeldt-Jakob disease, and it can also provide information about tumours and things like that, and cellularity of tumours. So this is why my bank manager would love it if we could get away with doing 1 or 2 scans, because we'd be able to scan a lot more patients. But each of these scans provide a different piece of information. And so these are the sequences that we talk about on the reports, and the patients will tell you, or if you've had one, the scanner will make different noises at different times, and that's because we're doing the different sequences. So not only can we do a sort of structural scanning of the brain, but we can also look at the vessels. It's MR angiography, and in contrast to CT, where contrast is always required, in MR there are both non-contrast and contrast-enhanced techniques. And an MRA of the neck to look at the carotid and cervical carotid and vertebral arteries, and an MRV intracranially, ideally contrast-enhanced scans, but we can certainly do both of those as non-contrast techniques as well. And an MRA of the circle of Willis is typically a non-contrast scan. So just to show you, so this is an MRA of the circle of Willis, and on the bottom right is what's called a source image of the MRA. So these are taken as about 150 or 180 very thin slices, and then they're reconstructed to form these angiographic images that you can see there. So this is no contrast, no ionizing radiation. So this is an MR angiogram of the circle of Willis, and this is the sort of quality that you can get. This is a patient who has multiple abnormalities. They've got an aneurysm of the ophthalmic artery, and you can see that you can't see the left internal carotid artery, and this is a patient who has an occlusion of the left internal carotid artery and a right ophthalmic aneurysm. This is a contrast, and just to tell you, this extra sequence, an MRA of the circle of Willis, takes about 3 to 4 minutes as an added sequence when doing an MRA of the brain. This is a contrast-enhanced MRA of the neck, and you can see that we can get from the aortic arch, the intracranial vessels. This is a patient who actually has an aberrant origin of their right subclavian artery, but you can see beautifully this is, and we can rotate this through 360 degrees. This is just a sagittal reformat, and you can see in beautiful detail the cervical carotid arteries, the carotid bifurcations, and also the vertebral arteries. And this takes about a minute. It is a contrast-enhanced technique. And again, this is a patient with a significant stenotic lesion of their proximal right internal carotid artery, and you can see that they have an ulcerated plaque there. And this is the sort of detail that you can get with a contrast-enhanced MRA. This is a contrast-enhanced MRV, and again, you can sort of appreciate the detail that you can get with a contrast-enhanced MRV. This sequence takes normally about 2 minutes to acquire. It's very important that you help us to help you. I can help you to look very clever if you give me just a little bit of information. So if I get a generic request that says MR brain, you will get a generic MR brain. If you write on the request query trigeminal neuropathy or third nerve palsy, then you're going to get a targeted scan of the skull base. And I just want to show you what the difference between those two is. So this is a patient who has had a generic, and when I say generic, it's a very high quality scan, volumetric imaging at 3T, but it's a routine MRI of the brain, this is what it looks like. And this patient actually had left trigeminal neuralgia, and these scans were actually part of a more detailed study, a scan of the skull base. And so what you can see here, unfortunately these have not flown in quite the way I'd hoped they were, and it's obscuring it, but you can see where the yellow arrow is down the bottom there, that this patient, so these are thin slices, so these are 1 millimeter thick slices, and they're what's called isotropic, so they're 1 millimeter by 1 millimeter by 1 millimeter, which means that we can reconstruct these in 3 planes. So you can see in the top right-hand corner, I've got an axial. In the middle, I've got a sagittal. And the bottom left, I've got a coronal, fat-suppressed T1-weighted sequence. But these have all been obtained from one data set and reconstructed. And this patient has a small lesion, which you can see where the arrow is in the left Meckel's cave, which is enhancing avidly. And this is a left trigeminal schwannoma. Now, this is this patient. Right? And I can't see that. You can't see, well, you might get a hint of it there on the flare sequence, but it would be very easy to walk past this on a routine brain MR, whereas with the dedicated skull-based protocol, you obviously immediately see the pathology. We can also do what's called a high-resolution diffusion-weighted sequence, which takes longer. It's about a 3 or 4 minute, about a 4-minute sequence. And there's 2 millimeter contiguous thick scans, which we can again reformat. So you can see the coronal reformat there is actually from the axial data set. And the history provided to us was query TGA, transient global amnesia. So in that situation, we're looking for very small areas, as you know, of altered signal intensity in the hippocampus. And so in that situation, we do a high-resolution diffusion-weighted sequence, and you can see there's an approximately 2 millimeter focus of altered signal intensity in the tail of the right hippocampus. And it's important to be able to find these things, because then you can reassure the patient you know exactly what it is that you're dealing with. You can say, yep, we've found the lesion in the hippocampus. It is what is typically seen in TGA. So you're comfortable that you've made the diagnosis, and you're comfortable in being able to reassure the patient that your presumptive clinical diagnosis is accurate. This is another patient with a high-resolution diffusion-weighted sequence. On the left was the routine diffusion-weighted sequence. This was a patient who was referred by a neurologist, and the neurologist said that he was sure that the patient was very confident that the patient had had a very recent small brainstem infarct. He had an internuclear ophthalmoplegia, acute onset in a patient with vascular risk factors. And so I got the long-suffering radiographer to repeat the diffusion-weighted sequence doing the high-resolution technique. And you can see there where the arrow is, you can see the small infarct in exactly the right anatomic position in the region of the medial longitudinal fasciculus. And again, this is important because you can tell that you know what you're dealing with. Rather than saying, I think you've had a brainstem stroke, we can say, we can see the small brainstem stroke. The other thing is dissection. And you obviously encounter patients where there may be a clinical concern of dissection. This is a situation in which I actually like to perform both a contrast enhanced and a time-of-flight MRA. And the reason for that is that in dissection, you're looking for an intramural hematoma. And on the right is an axial slice from the time-of-flight MRA. And you can see where the arrow is, you can see a crescentic hyperintensity there. And that is the intramural hematoma of a right a dissection of the right internal carotid artery just proximal to the skull base. On the contrast enhanced MRA, which is on your left there, you can't actually see the dissection. What you can see is where the arrow is that there's some focal narrowing of the right internal carotid artery there, but you can't actually see the dissection. And that's why we perform both. And again, if we've got that sort of information, we can provide you with the scans that are going to help you to manage the patient. This is another dissection, again on the right internal carotid artery, just above the skull base, or just below the skull base, rather, where you can see the intramural hematoma on the right. And if you look at the normal carotid artery, the bright white round thing on the left is the normal left ICA. So most of the time, I think you're going to be ordering an MR. You know, in patients with headache, look, there are situations where a CT can be helpful. There's no question about that. In the setting of head trauma, where you want to exclude a parenchymal or extraaxial hematoma, a CT is a very good way to go and would still be the standard of care. If you've got someone who is very agitated, restless, and confused, then as a general rule, depending on what you're looking for, if you're trying to exclude a smoking gun in an elderly, patient, then a non-contrast CT to exclude a mass lesion is not an unreasonable approach. But if you're looking to try to confirm a clinical presumption of something like Alzheimer's disease and you want to look at hippocampal atrophy and things like that, then a CT is not going to be particularly helpful. Sometimes, in an effort to be helpful, a patient or some clinicians will order CTs because they're not Medicare rebatable for sensory hearing. MRs are not Medicare rebatable for sensory neural hearing loss and for pituitary dysfunction. Please don't do that, because if the CT is normal, they're going to end up with an MR, and if the CT is abnormal, they're going to end up with an MR. So either go straight to the MR, or if it can't be done through Medicare and the cost is an issue, then wait for the patient to see the specialist. And I just want to show you, this is an intracanalicular vestibular schwannoma. It's at the apex of the right IAC. It's a 3 millimeter diameter lesion. It's never going to be picked on CT. And I just want to show you here in the pituitary, on the right side of the adenoid hypophysis here, there is an approximately 2 to 3 millimeter focus of reduced enhancement, which is the increase in signal intensity on a T2 weighted sequence. It is highly unlikely that it's going to be picked on the CT. And as I said, even if it is, the patient's going to be referred for an MR to further characterize it. CT can play a complementary role, and this is a patient with a large intracellular lesion with destruction of the dorsum celli and extension into the prepontine cistern. And this patient did also get a CT because it provides information about the osseous anatomy, but the primary modality for diagnosis is MR. This is a patient who had a CT because they had trigeminal symptoms, and the scans from up the top on the CT are not normal, and it was appreciated that they weren't normal, and that was why the patient was referred for the MR. But I think you will agree that the MR obviously provides much more information. This is a patient with a dumbbell trigeminal, very large dumbbell trigeminal schwannoma. And this is dedicated skull base imaging of that same patient. Question number 2, contrast is typically required when performing an MR brain for the investigation of headache. True or false? Stephen, do you have any more questions whilst we're waiting?
While we're waiting, I just back to the discussion about other metallic foreign bodies that might have been put in some years ago prior to MRIs, like aortic clips, abdominal surgical clips.
Not a problem.
Yeah, not a problem at all if they're very remote.
No. Yeah. Yep.
And spinal cord stimulators was the other one.
They are a problem. Yes, spinal cord stimulators are a problem. Yes, they can't be you can't scan those patients. Normal surgical clips and things like that. The Zenith grafts, the Zenith aortic grafts. We used to think they were not MR compatible, but then they were compatible at 1.5T, and now they're compatible at 3T. So they don't form a contraindication, and normal sort of vascular clips and sternal wires and all of those sorts of things, all of those are perfectly safe as well. And look, if you're not sure, you know, by all means, contact your local MR practice and just say, look, I'd like to refer this patient for an MR, but I just want to be sure that it's safe for them to have it. And normally, that can be sorted out. Our staff, a combination of the radiographers and the secretaries, the MRs, secretaries and radiographers spend a large part of their time sort of, making, checking out those sorts of things or answering those sorts of questions. So if you're not sure, by all means, just ask the question.
Thank you. And one other question was, how numerous and how accessible are radiology, MRI scanners for obese people? Are there many around Sydney?
Yeah. So the big push has been because our individual and collective girths are increasing. The MR manufacturers have invested a lot of money in developing larger bore and shorter bore magnets for this very reason. So there are now a number of short bore, wide bore magnets. We would routinely, when I say routinely, we would scan patients, up to about 150 sort of kilos without major dramas in some of the scanners. Some of them are not, the bore or hole, the donut is not as big, and with very large patients, again, it may be worthwhile checking with your local practice because it just depends to some extent on the manufacturer and also how old the scanner is, because obviously the older scanners, the donut that the patient goes into tended to be smaller. The reason for that, just very briefly, is that it improved the image quality. Hardware and software, the manufacturers have now been able to open up the donut so that the hole is a bit bigger without compromising the image quality.
And one further question is the indications and advantages of standing MRIs.
Right. So I'm not okay. So theoretically, it is a good idea because this is particularly pertains to the lumbar spine. Because obviously, when someone is supine, you're not doing them when they've got axial loading. And when they're erect, and so the biomechanics do change when patients are erect. The problem with that, and there always is a problem, is that the upright scanners are very low field, and so the resolution is generally not nearly as good as with a conventional scan. So I think that you probably lose more than you gain.
The poll is in now, and in response to the question about typically requiring contrast used in MRIs, true 14% and false 86%.
Yeah, and for the routine patient, so the patient who comes to you who's got headaches, and they've just had keep getting headaches, and there are it's bog standard headache. Then we would not routinely administer contrast. Now these scans are being supervised as they're being done. So obviously, if we see something, then we will administer contrast. Sometimes the other thing is that we will sometimes give contrast when patients have a history of a past malignancy. So let's say someone comes in and we get a patient to fill in a questionnaire as well, listing their symptoms and relevant past history. And if someone comes in and they've been referred by their GP and they've got a new onset of headache and they've got a recent history of breast carcinoma or melanoma or something like that, and they've got some white matter dots, even though those look fairly bland, we will often administer contrast so that we can be confident that there's no evidence of intracranial metastatic disease. But for routine, MRI of the brain for patients with, for investigation of headache, contrast is usually not required. Okay. Any other questions, Stephen?
We might push on. Thanks.
Okay, right. Push on. All right. So what I also wanted to talk about a bit is a couple of the pathologies that you will see because you're ordering a lot of MRs. You're getting these reports back, and I think there's often a vexed question for GPs as what the hell does this report mean? And a lot of it revolves around microvascular ischemic change or small vessel disease and microhemorrhages. And so I thought I would just spend a couple of minutes talking about that as well. Because as I said, the patient's going to say to you, well, what the hell does it mean? Am I going to live, die, and, is it significant? Is it bad? So cerebral small vessel disease is one of the things that we encounter very frequently. And it basically is a spectrum. Small subcortical infarcts, white matter hyperintensities, lacuna infarcts, microbleeds, and dilated perivascular spaces, and it forms a spectrum. And different people, both neurologists and radiologists, call them different things. My favourite term is microvascular ischemic change. It can also be called leukoariosis, small vessel disease. White matter hyperintensities of presumed vascular origin. When I first started doing MR, and this was a real term, they were called UBOs, unidentified bright objects, which was a very useful term. The significance of white matter hyperintensities, presumed microvascular ischemic change, is that whilst they may be asymptomatic, they are strongly associated with vascular risk factors, hypertension, diabetes, smoking. And so they're a very good surrogate for vascular risk factors, and they are associated with cognitive impairment, gait disorders, and depression. So whilst they in and of themselves are not or may be asymptomatic, they can be a marker for an underlying more significant sort of problem. And this is basically what they look like. On the top two slides are a FLAIR sequence, and the bottom two are T2 weighted sequence, axial scans. And remember I said on FLAIR and T2, pathology is white, and you can see there are multiple small white dots, which are peripherally distributed. And this is where the art rather than the science comes in, and you as clinicians are much more aware of the art of medicine than the science, than I am. But the question is, what constitutes, what's normal and what's abnormal? And that depends largely on the patient's age and the number. And unfortunately, it is a subjective rather than necessarily an objective thing. And so you can see in this patient, they have more extensive disease, particularly in the bottom right, where they've got areas of confluence and they've got changes in the pons, which you can see in particularly well on the flare sequence. And then you've got another pattern here where you've got fairly extensive changes in the periventricular white matter. And this is what you can also see on CT as these periventricular white matter low densities. And these are the sort of the very typical patterns that you can get of microvascular ischemic change. So as I said, you know, the severity to a large extent depends on the patient's age. So what causes it? We're not sure. The pathology of it, we're not sure of what the pathology is. Some of it's demyelination, axonal damage, and it's probably a spectrum, and it probably does change. The other thing is microbleeds, because small vessel disease and microbleeds go hand in hand. And one of the difficulties, one of the both strengths and weaknesses, well, not weakness is the wrong word, but one of the strengths and curses of MR is that we see a lot more. You know, and at 3T we see even more than we did at 1.5, and with a susceptibility weighted sequence we see more than we used to do with a gradient echo sequence. And so now we see lots of microhemorrhages on a susceptibility weighted sequence, which on the far left hand scan there are these black holes that you can see. And what we know is that these are found at autopsy, that they can be seen as you know, as part of the aging process, and they can be seen in the setting of amyloid angiopathy. And what we can also now see is subarachnoid hemorrhage. And when I was a medical student a long time ago and doing my neurology training, you always used to think that all subarachnoid hemorrhage was symptomatic, you know, patients presenting with terrible headache and meningismus. But we know from MR, so this patient, the top right hand there, all of that black etching of the sulci, that's old subarachnoid hemorrhage. But this patient has never clinically had a subarachnoid hemorrhage. And this is amyloid, almost certainly amyloid angiopathy with both parenchymal microhemorrhages and subarachnoid hemorrhage. And this sort of pattern is not that of aneurysmal subarachnoid hemorrhage. And as I said, the pathology of microbleeds, amyloid angiopathy, and it can also occur in hypertension. The hypertensive microhemorrhages you would typically see in the cerebellum pons, basal ganglia, and thalami. And the parenchymal, the microhemorrhages with amyloid, you tend to see peripherally in the cerebral hemispheres. But there's almost certainly a degree of overlap because often your patients have hypertension as well, you know, particularly older patients. So there's often an overlap. I just want to quickly finish up with a little bit on epilepsy. You're very familiar with the causes of epilepsy. Please don't order an MR in the investigation of epilepsy. Yes, if someone has had a head injury or something like that and they have a seizure post-head injury and you're concerned that there may be a parenchymal hematoma or something like that, then yes, most definitely order a CT. But otherwise, in an outpatient setting, it is much better to order an MR. This is a patient who had a first fit, and this is a patient who actually had a cerebral abscess. And if you can see the arrow there, that is pus in the frontal sinus, and you can see there's dehiscence in the posterior wall of the frontal sinus, and it is communicating with the frontal lobe. And this patient had a frontal abscess. And you can see, unfortunately, this was supposed to fly in, but it hasn't happened. You can see beneath that center scan is a diffusion weighted sequence, and you can see this white thing on the top left and the black thing next to it. That's the ADC map. That's the classic appearance of an abscess on the diffusion weighted sequence in MR. This is not a tumour. We can be very confident of that. And this was demonstrated to be an abscess. We see things that we know that when I was certainly doing my neurology training, we always thought were elliptogenic, but we now know patients who are normal have them. So where the white arrow, the yellow arrow is, this is a subependymal grey matter heterotopia. And you can see on the flare sequence and the T2 weighted sequence that this is tracking grey matter. It's what's isointense to grey matter, and it has the classic appearance. Although this can be a cause of epilepsy, because we're doing so many more MRs, we see patients who have never had a seizure in their life, and I reported one only this last week, who can have quite extensive subependymal grey matter heterotopias, and they're having an MR for a headache, and this is an incidental finding. And then the other thing is medial temporal sclerosis. And again, this is characterised by increased signal intensity in the hippocampus, which you can see in the coronal scan on the right. That's the flare. And this is a volumetric scan, so this has been done at 3T, and we can reformat this in both the axial and the sagittal plane as well. And you can see on the T1 weighted sequence, remember I was talking about this, it's great for anatomy. You can see that where the arrow is there, that's the left hippocampus, and it's clearly much smaller than the right hippocampus. And this is the classic appearance of medial temporal sclerosis. So question 3, is there a role for CT in the workup of a patient following their first fit? Never, sometimes, or always. Any other questions? Stephen, whilst we're waiting for that?
While waiting, yes. One viewer asked, how do we get MRA for GP referrals, saving on specialist referrals and unnecessary CTs? This comes back to the question of, I suppose, when a GP referral is Medicare rebatable.
Yes, yes, and you're very familiar with the indications for rebatable GP referrals. Yeah, and look, this can be difficult, and sometimes, and obviously it also depends on the patient's financial situation, but sometimes, depending on your relationship with the neurologist or the neurosurgeon, you know, if you ring them and you say, look, I think, you know, the patient's got this, and you know, if you can expedite it, and if it's not Medicare rebatable and the patient is in a position to be able to pay for it, it saves them a second visit to the specialist. You know what I mean? If they get an MR scan and they pay for it, but that's not always an option. As I said, we're not the arbiters, obviously, of who is eligible for GP referred scans.
Right, thank you. And there's an increasing body of evidence showing transcranial magnetic stimulation has a role in treating depression. Have there been any studies showing MRI improving depression in MRI scan patients?
You know, I want to take credit for that because you know, sometimes patients will, I have no idea how, but they fall asleep during it, and they say, you know, it's the best sleep that I've had. You know, the baby's kept me awake for the last 2 weeks, and I had a really nice snooze in the scanner. And I've had the odd patient tell me how much better they felt after the scan. And I've been very, I would love to be able to bill for a therapeutic as well as a diagnostic scan. But no, a TMS is, although it's magnetic, it's very focused, and unfortunately, there's not been a therapeutic role for MR demonstrated yet.
All right, and there we go. And I think we'll go back to the poll now.
Yep.
It's now closed, and the answers, the question, never 14.6%, sometimes 74.2%, and always 11.3%.
Yeah, and as I said, look, I think particularly if you've got someone where, you know, there's a head injury or something like that, or you can't get access to an MR in a timely fashion, then I think certainly in the setting of a post-traumatic seizure, I think a CT, you know, it can be done very quickly, and you can make sure that you're not dealing with something that needs neurosurgical management. And if you can't get access to, you know, MR in a timely fashion, to make sure that you're not dealing with a, you know, significant intracranial pathology. But if you've got someone who has a, you know, first seizure, who makes a full recovery and does not have any persisting neurologic deficit, and you can get an MR in a timely fashion, and they don't have a contraindication to it, then I would proceed to MR rather than CT. Look, I'm just about out of time, but I just want to mention a couple of other things. You will have heard and read about there are advanced techniques. We can do a lot of things these days: MR spectroscopy, diffusion tensor imaging, perfusion scanning, and functional MR. These tend to be used in neurosurgical planning for tumours. There is also an increasing move to volumetric imaging, and in particular looking at volumetrics in patients for evaluation of dementia and things like that. Whilst I think that this is definitely, we're moving in this direction, I would just like to sound a note of caution about this, and I just want to end with these two scans. And you'll probably think that I've got the dates wrong, because the top scan is from May 2007 and the bottom scan is from December 2008. And the top scan, the patient looks to be atrophic, and the bottom scan, the patient looks to have normal brain volumes. But the dates are correct. And this is where I think that these sort of volumetrics for atrophy and dementia need to be very much in a clinical context. At the time that the patient had the top scan, he was on high-dose steroids and had tuberculosis and had been diagnosed with tuberculous meningitis and was on high-dose steroids. And 18 months later, he was off therapy and off steroids. Now, he clearly was not atrophic, because atrophy is an irreversible, atrophy is neuronal loss, and it is irreversible. What he had then was cerebral shrinkage. He had dehydrated brain cells. And you can see what I sort of call, for want of a better way to describe it, walnut brain in patients on high-dose steroids, patients who are malnourished, patients who've just had dialysis. And you can get diurnal variations in brain volumes. And so I think whilst I think that there is a great role for volumetric imaging moving forward, and we will do more and more of it, clinical context, as always, is all. And I'll finish up with that one. And if anyone has any further questions. I put them to sleep. So can I build on that?
Yeah, no, here we go. Are most patients asymptomatic with these microvascular changes on MRI, was the question?
Yeah, yes and no. So, we'll often see, older patients, with some mild cognitive problems, and they've got a moderate burden of microvascular ischemic change. Now, that's not necessarily causative, but it certainly can be correlated with it. But as I said, it is more importantly a marker for vascular risk factors. And so, and particularly in patients, and we're seeing a lot more of it, in patients in their 50s and 60s, who've got sort of microvascular ischemic change, which is more than I would like to have in my head. And those are the patients where, you want to get onto their triglycerides, their lipids, smoking, blood pressure, you want to sort of reasonably tightly control their vascular risk factors.
Right, that's great. And finally, with microhemorrhaging, can this imaging, can the MRIs be used to predict poor outcomes for sports people with head injuries?
Absolutely, and we're well, yes. So we're actually scanning a lot of sports people, particularly the footballers, obviously with their new concussion protocols, and with the susceptibility weighted imaging, we see hemorrhagic axonal shearing injuries. And the other thing is, just anecdotally, when I was doing my neurology training, we used to see patients who had persistent sort of post-traumatic symptoms, and the CT was always normal, and there was a question of often of whether in more unsympathetic times whether it was overlay and things like that and secondary gain. And I continue to be astounded at patients with a GCS of 14 or 15 who have stigmata of a traumatic brain injury with hemorrhagic axonal sharing injuries, and we're getting much better at detecting that. So this does not have to be the knocked out for unconscious for 15 minutes scenario. You can see these changes with more, shall we say, sort of less significant, apparently less significant injuries.
That's great. All right, well, thank you very much, Lynn. On behalf of all the participants tonight and IMED, I'd like to thank you very much for your wonderful presentation. I think it's very relevant to us general practitioners, and I think we're now better placed to undertake the initial investigation and management of patients with unexplained chronic headaches and seizures. Once again, thank you to IMED for producing tonight's webinar, and finally to the GP attendees, thank you also for attending. Your large number of questions came through indicated a very high degree of GP participant interest and engagement. I'd like to remind you, the GPs, to complete their evaluation on tonight's webinar. And at this time, I'll take you back to Kate. Thank you, Kate.
Thank you everyone who participated, and Dr. Masters and Dr. Green, thank you for your time this evening.